that just leads us on to our last but not least speaker, who I will introduce now. She's here with us today in person, Komal Deepak Kumar. So Komal works as a diabetes obstetric dietitian in the NHS and has a research interest in endometriosis and fertility. She has 16 years of experience as a dietitian in different specialities such as endocrinology, gastroenterology, bariatrics, paediatrics and oncology, which gives an all-rounded approach to her dietetic treatments. Currently, Komal serves as the chair of the Maternal and Fertility Specialist Group at the British Dietetic Association. She aims to contribute towards, streamline and facilitate timely evidence-based dietetics for patients during preconception and pregnancy. She has contributed towards the development of patients' resources for pregnancy and male fertility at the BDA and towards guidelines for weight management for women with infertility with practice evidence in nutrition. She is also part of a pilot study in association with the University of Plymouth on understanding functional gut symptoms in endometriosis, with recent publication and Best Abstract Award in the Maternal and Fertility stream at the BDA Research Symposium in 2022. Her latest publications this year are developing of a nutritional screening tool to identify the need for dietetic intervention in male infertility, and nutritional practices and dietetic provision in the endometriosis population with a focus on functional gut symptoms.
Thanks a lot, and I think it was a fabulous line of speakers, nicely tying in what I'm going to say. I will bore you with Mediterranean diet as well, just FYI, yes. But I'll try to give my version of it, hopefully. All right. Yeah, so I do have a research interest in endometriosis because I felt like women, and there are other individuals as well who have endometriosis, really need the attention and dietetic care, which has not been there. And I tried to explore through my gastro clinics and try and get more people into that clinic, but it was always like, no, the diet is not the cure, and I was always confronted with those kind of questions, which is what led to the research more organically. So endometriosis is the presence of endometrial lining, which is the lining that covers inside of the uterus, anywhere outside the uterus, and that can induce a chronic inflammatory reaction. Its cause is very uncertain. It is linked to estrogen. So long you have been hearing about the hero side of things of estrogen. This is a little bit of the anti-hero side of things as well. And there's certainly no cure. Even surgery is not cure. I see a lot of individuals who, after surgery, still have symptom profile. I work with surgeons who send patients in, so please do link in with your local teams. There is a cohort of patients who need your attention, and with our current knowledge of dietetics itself, we can do a lot. So it affects a lot of people, like 1.5 million in the UK, which is in line with the number of people affected by Crohn's and celiac. So, however, the research is heavily underfunded in comparison. So we do have a lot of project avenues. If you're thinking about something, all the students right here, this could be an area you could be thinking about, because there is a lot we can do as well. It can impact in different ways, from pain, lack of energy, depression, isolation, inability to conceive. Now, it is linked, like what Claire was saying in the very first talk. If you're not planning to get pregnant, you don't need to worry about it. No, it affects a lot more than just fertility. And it has also a very debilitating impact on their work and social life. During my interviews with these individuals, they time and again told me how they had planned what they want to study, what they want to work as, how limiting it can be in their flight, is massive. So what these lives could have been, should they have had better symptom control, is massive. And that's where I think we can start showing promising results by intervening. So endometriosis symptoms, I have spoken about them. Another thing which is very common is the time for diagnosis is much longer. On an average in the UK, it can take up to 8 years. So that's knocking the doors of GPs time and again, not feeling heard, the frustration of feeling that the symptoms are in their head and not being taken seriously is a common trait. And that's the first 20 minutes of any research interview, any consultation. You have to accommodate that because they are bringing in their lived experience, exactly like what, and the way they plan their diets, the way they have looked into, with their capacity, the research that is available. Generally, they're extremely well read. So you have to be on top of your game when you're sitting there. And be honest with them. If you don't know something, then you can always get back and go through research. So we can't be perfect. Okay, GI symptoms is one avenue I feel like it could get our leg into the door when it comes to endometriosis services, because there's this huge overlap of IBS type of symptoms in this cohort. And this can be true just not with endometriosis, but any of the gynecological problems. You can think about, PCOS, you can think about menopause, you can think about fibroids, any of them are sort of linked. So there is this whole weird relationship of the hormones and the gut microbiome. There can be gut function as well. There's a huge link of gluten-free diets, so potentially there is undiagnosed celiac there as well. So all these aspects where dietitians, now we've got people working in PCN front, we've got Nusrat here championing that. So thinking about it like a first responder, what sort of diagnosis criteria should we be asking about? So you're thinking beyond just the basic sort of dietetic role. So I have spoken about this. Interestingly so, in the endometriosis audits, where you have centers of excellence, they only consider constipation as a symptom. They don't feel like diarrhea is part of the symptom profile, which I think is next step of challenging that based on the recent research papers that we published. That the symptoms can vary from just not constipation, but can go to the diarrhea profile as well. They can have a mixed profile. What I have seen in my limited experience in the past few years is there could be a cyclical pattern. It can be, they do have sort of like a unique phenotype of IBS where they do have a lot of abdominal pain, pelvic pain, diarrhea or constipation can be mixed and can vary at different times of their cycle. Weirdly enough, people who are on pills or HRT and on Marina where they don't get the period, still follow some sort of a cyclical pattern. So there is that hormonal impact which can be visible, but not so true in every case. So every case has to be taken on an individual basis. But it does help to understand what's their good day, bad day, how does it vary through the month, and which are the points which we can touch base on and provide tailored advice when it comes to management of symptoms. Yeah, I think I've spoken about that. So there's 2 to 3 times higher likelihood of IBS type of symptoms amongst this population. So diagnosis is, it does take up to 8 years. Now the reason why it could take up to 8 years is because you do need laparoscopic surgery to lead to the diagnosis. But in the UK, we do notice that there is a combination of methods used. Sometimes it's based on ultrasound, sometimes based on clinical picture that the patient is presenting with, where the consultant or the GP or somebody might tell them, I think you might have it. So we did have a lot of those as well, where we do have to, if you're thinking about in research perspective, then to notify whether it has been confirmed by a laparoscopic surgery or not. They do visit a lot more to the doctors because they have symptoms which they don't understand and they're trying to decode. So 21% visited doctors and in hospitals 10 times at least, and 53% went to A&E. 27% went to A&E 3 times or more. So all this kind of forms their passage, which is extremely frustrating as a patient journey. And the amount of trust they could have on the medical fraternity kind of diminishes as well. So there would be a lot of, are you sure? Is this what you want to advise me? What's the evidence behind? You would experience a lot more stronger voice as a patient, and it is good in a way. I think if I was sitting in that person's shoes, I would do the same, in fact even more. I could be paranoid, but that's okay. So it's good for a dietitian to kind of be a little bit patient as well whilst taking care of them. Okay, so the current treatments involve hormonal therapy, pain medications, and surgery. However, it might be partially effective. I've worked closely with the MDT in my current trust on an ad hoc basis whenever they do have MDTs. They do struggle and they try not to go in again, try not to provide a re-surgery for a patient, and if in case there could be something else that could be done to improve their quality of life, then it'd be great. And that's where dietetics comes to role. But like what Ro was saying, it's the whole struggle, and I think we are facing that in terms of business cases, trying to prove that it's effective. So we're working towards, a pilot and doing more research, enforcing, getting, any case studies, if you all have seen anybody in your practice, publishing those, getting that unified voice, because like Drew said, I'm only one person. So it would be great to get more voices from the dietetic fraternity. And I strongly believe in that, because I just kind of launched one idea one Christmas on Facebook, and it became a committee, and we're doing fabulously well. So I'm hoping that this would, maybe a few years down the line, I would think about it and say, oh, this turned out well. So there is huge potential of dietetics being part of these services. Okay, so current recommendations sadly put diet under the bracket of alternative therapies and do not recommend it. So it's a fight against getting better voice in these kind of documentations and guidelines, but I think we'll get there based on how strong we are as a fraternity. I strongly believe we can make changes to this, but based on this, it makes it harder. What are you trying to achieve? Is this one of your schemes? Is this a fad? You're not going to cure the endometriosis of it, but nor is surgery. So if you could be as invasive as surgery for symptom improvement, at least you could try, dietetic modification. So, yeah. So I told you that it's kind of put under the bracket of alternative medicine. Where do we start? So it is quite a minefield. And owing to time, I will not be able to kind of step into each aspect. But there are a couple of talks lined up in this front. So I will be kind of telling you all where I'll be talking about what, so that hopefully I see the similar smiles again. it is quite a minefield, but it's good at least that there is some sort of evidence. Now, these few reviews, why I've put it out there is you could go back and delve into it. I'll try to send out the links as well, so that you can explore. But there is strong evidence of diet playing a role in terms of symptom improvement, in terms of reducing risk factors which can lead to progression or development of endometriosis. So if somebody's got that sort of history where they do have, genetic predisposition or being estrogen predominant, they kind of know that, then they can start making these lifestyle changes. Obviously, I'm not backed up with studies to tell you what was the impact of intervention because we are not there yet. It's early days. But, at least there's something out there which kind of supports that we can make a difference. So, a lot of studies are based on weak and low sort of grade evidence. And here it suggests that no significant effect of self-management strategies was suggested compared to the placebo. But this is self-management and it's not necessarily dietetic-led. Intake of fatty acids, antioxidants, and combination vitamin minerals do have a positive effect in terms of symptom management. Now, these are symptoms you're talking about, pain during or after sex, or, struggling on the toilet for almost 10 minutes, not being able to go to the loo. It can be extremely, debilitating IBS, which can have an impact as well. So those kind of symptom profile, we can make a difference by helping them reduce and making it more livable in terms of pain and distress. Okay. However, there is a huge risk of bias as well, because any nutrition studies, it is difficult to kind of, eliminate a lot of bias. There's a reporter's bias, there's interviews bias. I had a chuckle almost with my recent paper when I completed it. My guide put in a statement. There is a huge possibility of the interviewers being biased. So I was like, definitely, I can possibly be contributing to the bias there. So but there is a huge impact, positive impact on pain perception as well. So what we need to understand is how we perceive IBS to be. It can be because of osmotic action, it can be increased visceral sensitivity and inflammation. So you've heard these words time and again today, so I'm not going to kind of repeat on that. That's the same sort of thing which could press against and cause pelvic pain. So the referred pain could potentially be improved as well. What we found in our survey, which I'm going to talk about, is there was sort of, a correlation that we found on pelvic pain with IBS symptoms as well. So hopefully it can be hypothesized that if you improve one, the other has an improvement as well. And overall, there's a pain threshold of a person, and that kind of comes to an improvement as well. That there's only so much a person can tolerate, so it would help overall. So low FODMAP diet, this was the study I got inspired by, and I started off my venture, and I spoke to Judith as well in Australia. She's a lovely endometriosis nurse. She went out there and she started, with the low FODMAP approach. And out of these 160, only 36% had concurrent endometriosis. Now, there might be a lot in our clinics as well who might be having endometriosis in the background, but we might not realize. Sometimes, low FODMAP diets are given out in groups. You might not know the entire history. So documenting these aspects, because when we did the dietitian survey, we were struggling to recruit dietitians, because sometimes we might not even realize what is there in the background. So if you are noticing that it might be playing a role, then please do contribute towards smaller publications or articles or awareness, advocate it on your behalf, because that will start collating as a bigger piece of work. Now, 72% of those with endometriosis and IBS had an improvement in GI symptoms with low FODMAP, versus only with IBS there was only around 49% of an improvement. Now, this is a bit of a controversial slide, and I know I've heard a lot of feedback about it, because last time it was presented, I had some of my colleagues who sent me, "What is this? Why do you start with all these kind of diets?" Now, this is what evidence is presenting us with, and we do see a lot of mixed practice. There was a recent sort of systematic review done as well, with a nice sort of arrangement of different approaches that individuals with endometriosis try out and feel sort of an improvement with it. Unlike what the first slide said, this one suggests that some sort of dietary modification does help. So there is some sort of promising results. So Mediterranean diet, interestingly so, in my head, I was like thinking, why haven't they considered a first line? Because we think about a first line approach when it comes to gut health. Why isn't that there in the sort of flow chart? So in a way, they are thinking about regularizing, getting regular meal pattern, getting sort of, your meals, snacks planned out so that you're not indulging in something which could potentially have a downside, or missing meals and those sort of things. But there is more to it in the story as well. Now, the low nickel diet and low FODMAP diet, but after referring to gastroenterologists, I would really put dietitians in the map there. Just not at all biased. So that can also help. And of course, there are a lot of micronutrients. Now, here they've spoken about it for 6 months or so. However, that's because there's not enough evidence, so they don't want to take the risk of providing supplementation for longer. When I see patients in clinic, it's more relying on what their clinical profile is like, what their intake is like, what their serum levels are like, and then I decide whether I really want to give them any long-term supplements or not. And it would be more of a food-first approach. So, I was kind of, picking my brains a little bit when I was like, what is this low-nickel diet? One, there's not enough evidence, long-term evidence of, the safety and efficacy of it. But we do, do our diary checks and, food symptom evaluations with our patient population. So this could be like an area where if you notice a trend of certain high nickel foods, then you can then explore if they've got some skin related issues as well, and if they require a patch test to then evaluate. But there's not a lot of evidence to support, and there's not a long-term safety and efficacy of the diets being evaluated. I found this extremely sort of relevant, though this was a paper taken in terms of IBS. I felt in the front of endometriosis there could be a potential role of a combination action of the same, and I know a lot of them come with having trialed multiple diets and multiple restrictions already. So it would be good to kind of start evaluating, have a more flexed out approach to what you might manage them with. It might be sort of like a semi-FODMAP thing if they already kind of associate with their symptom profile. And of course, this would be again another avenue to start thinking in the terms of Mediterranean diet. There are obviously a lot of gut health improving aspects and low FODMAP foods as well that kind of overlap in both these dietary approaches. So though we might be going by one approach, when we are, exploring what healthy changes we can make, we might be making some of these overlap decisions anyway. So what I felt is missing is, one, most of the evidence is not dietetic-led. We need more research being voiced out from dietitians. There was lack of the first-line approach. We don't need to jump into restrictions right away, especially if you can meet them in different parts of their journey. I've met individuals who were reported that they had endometriosis as early as their puberty, and even sometimes after menopause they continue to have some symptom profile which is lasting, which again is not something that's believed. Most people believe that it ends when they stop producing estrogen, but they do have lasting impacts. So Mediterranean diet does not have any sort of long-term downsides. So that would be a great starting point. And however, there are certain dietary aspects, like for example, cruciferous vegetables, Brussels sprouts, and those sort of things have been linked with reducing estrogen production as well, and helping in excretion of excess as well. So those sort of aspects, sometimes they might take it to the other extreme, and if a person's having diarrhea already, predominant IBS, and they're coming to you with having only that, then that's the point where you have to put on the clinician's hat and tell them, no, you're not overdoing any extreme, you're kind of coming back to neutral because you're listening to your body and not to some evidence on Dr. Google. Yeah, so it is kind of individualizing that approach a little bit, and expectations are extremely heavy as to they want to stop, reduce, or halt progression. Discovery calls would be like, I tried the low FODMAP, it did not stop my endometriosis from reoccurring. So that sort of is the expectation set in the beginning, and which is understandable. So that's where a lot of fact and myth busting comes to role, where we can explain to them what's possible by diet and what's not possible, and set very realistic expectations from the beginning. And a lot of them have tried multiple diets, are on multiple pills. Sometimes it can be difficult because if their bowel is impacted extensively, they can require long-term nutrition support, enteral or parenteral as well. And main concern, what I think I'm fighting my corner at the moment, is there's huge lack of funding of dietitians being part of this MDT. And we need to potentially be able to show, hopefully we will one day, to be able to minimize the requirement of surgery or resurgery in these patients. And however, this is one of the main agendas as well, though they've put it in the main agenda to find non-invasive treatments to reduce surgery. So we have to just get dietetics there. So low FODMAP advice may be beneficial, Mediterranean diet may be beneficial. There are other role of nutrients as well, which is not extremely clear, but there are some sort of pointers which could be a starting point. So where we've got so far as a team is we are exploring what could be an intervention model, which could be the next stage of the study. This was our first paper that's come out, and so you could go and explore what we've done. It was more of a need provision sort of comparison. So there was a survey, getting the help from Endometriosis UK. I managed getting 1,385 individuals respond in the span of, it was around 6 weeks, 4 to 6 weeks. That was the response from individuals with endometriosis, that yes, they do need help. A lot of them were pleasantly surprised that, oh, So that's my bowel symptoms. Nobody's made the connection till now. And however, I also ran a concurrent dietitian survey, struggled, managed getting 21 dietitians. So thank you. There are some voices out there, supporting the cause as well. I'm not alone, which felt like a big relief. However, there is a huge sort of gap in the need and the provision of dietetic provision in the care. Yeah, so I think we've spoken. I have presented this in multiple occasions, but I am just going to briefly kind of breeze into it, saying that yes, a lot of them had been diagnosed with IBS already. However, a lot more had gut symptoms. So a lot of them did not report they had the IBS diagnosis. However, they still kind of followed the similar pattern when it comes to gut symptoms. And it was a mixed pattern. It was not just following constipation. So we are going to get in touch with, the endometriosis board as well, where we will be telling them to work on their audit tool, which only mentions constipation. Okay, and there is huge amount of supplement intake. If they're not getting help, they have to help themselves. So there is a lot of self-help that is noticed amongst these individuals, and sometimes it's overdone. The nutrient that they might be needing most, they might not be taking. They might be taking a whole other kind of array of nutrients that might be aggravating gut symptoms as well. So you are kind of exploring what might be needed. So I will just kind of get to one slide which explains most of it. Dietetic need is not restricted just to IBS here when it comes to endometriosis, but it was just one of the ways we wanted to get our leg in the door, to kind of announce that yes, this is somewhere we can definitely help with. But a lot is kind of under the umbrella. You can call it disordered eating. Eating disorders are huge. They get a lot of supplement usage. This is very interesting. 50% felt the need of a dietitian. Only 13% had a dietitian review so far, which is a bit strange because 71% had IBS. We do have quite a strong fraternity of gastrodietitians, so you would think that they would somewhere get a referral. They would hopefully get a referral for their restrictive eating pattern or their sort of IBS symptoms or unintentional weight loss. But it is not coming through. This stands in the way. Having endometriosis in the baggage becomes, this is normal. It's normal to have gut symptoms. It's normal to kind of be a little bit paranoid, which is sad. So this was the dietitian survey which was done, and I think I was glad to find that, yes, I was also practicing in line with all my fellow colleagues who were kind of utilizing the Rome 4 criteria and utilizing the low FODMAP, because rather than going down the road of any diets which are not having a lot of evidence to back it up. However, a lot of them, dietitians practicing in the area, were extremely experienced. So kind of taking on those kind of complex cases came with experience as well. But there is a huge need for developing more training and written resources. For that, we need more research. So I think it's a cycle that we are stuck in. I am not going to delve too much into this because this has been accepted for oral presentation on the 4th of July. So hopefully I'll see you all at Nutrition Society Summer Conference where I'll be talking a little bit more about this. We've also submitted a paper. hopefully, we've not got a rejection, so hopefully it should be coming out soon. What I would like you all to notice here is this was extremely interesting, where there was this person I had interviewed with who used to go off on a liquid diet for up to a week and then would start feeling better. However, it's not sustainable, but it's a lot of effort. And I know you're not getting all the nutrients, but then they followed that kind of cycle every time they had a flare-up of their symptoms. That's where, maybe a gastrodietitian could have explored, is it Crohn's, is it celiac, what's going on there? And if they are going away on liquid diet, it is a sustainable liquid diet rather than something which doesn't have any nutrition at all. So those sort of aspects I felt strongly dietitians could be involved. You hear this a lot. Well, I'm on a gluten-free, dairy-free, soy-free, chocolate-free, caffeine-free, ribene-free, tomato-free diet. Now, here is, every case is so different when you're managing patients with endometriosis. It can encompass a lot of different kind of cases. They can come to you for fertility issues, or they could come to you for gastro issues or eating disorder. It can kind of be hidden in the bracket. In endometriosis MDTs, they kind of have a group of clinicians who sit together where they utilize each other's specialty. I utilize my colleague dietitians where I can then refer if in case it's beyond my specialty and my strengths. So I think we have to start utilizing that strong network that we have to signpost as well. This was an extremely interesting case I recently saw. So this woman had 13 miscarriages, and she had 3 babies in the buggy outside, with the 4th one that she came to see me in the GDM clinic. I was like, okay, why are you getting pregnant so much? And she's like, this is the only time I feel normal. And she had endometriosis symptoms whenever she's not pregnant. But nobody sent her off to get progesterone rather than getting pregnant. I know, but it was very sad. She looked like the face of death. No nutrients in her body. All the results of her blood tests showed a deficiency. Everything was deficit. But she had to keep getting pregnant to get progesterone. So not 2 patients are the same. You could see them in sort of different backgrounds. You might be seeing them already. So we do have them definitely in our caseload. I would not agree that we do not see endometriosis patients. I'm sure it's kind of not coming to you directly, but there is somewhere a link impacting their symptom profile, behavior profile, talking to them, listening to them, documenting case studies, please, anything interesting, please, please, please publish. Get in touch with our committee as well. We do fabulous work, shouting out with any sort of championship in upgrading, and maybe we would get something a little more in line for the students as well. Thank you for the suggestion. So next steps is we need to consolidate what would be an approach for intervention based on evidence. Still thinking about it. Even this morning when I was preparing for this talk, I was like, this is new, all right, I'm now going to write it down. So I jotted down so many points, but I still, at the end of it, don't feel like I've reached a consensus yet. So we do need an intervention study. I was brainstorming with some of the endometriosis nurses if we need a group approach, should I set up something? But then I need to take a step back because none of my patients' profiles match at the moment for me to put them into a group. So I need to first understand what I'm trying to address and then set something up. So However, we need to support the dietetic force to be able to understand different varying needs that could, be coming up in the name behind endometriosis. Okay, so these are some of the take-home messages. As of now, we've got low FODMAP for the gut health side of things. Mediterranean diets do help as a baseline. But however, do treat your patient, listen to them, go with the cues, individualize it, whether it's for the macronutrients or the micronutrients. You have to kind of, listen to your patient and decide an individualized approach. And I've not kind of given you off everything. And there are some more information that will be coming up in the next talk at the BDA Maternal and Fertility Day, which is like a virtual one that we've got. Ro is our fabulous study day coordinator and vice chair and my successor. So we are going to kind of see a little more kind of debates, and I think there'll be a lot of drama around phytoestrogens and progesterone. So I'm not going to be talking about all that today, unless, there are some questions. So I thank Dr. Kate Maitland. She really got me out of that sort of research frustration that I was facing, because I'm not a researcher by background, but I was facing a clinical question that had no other way out but to do some research alongside. Dr. Nitesh Narvekar, who's consultant at King's as well, very patient, getting me involved in designing what our survey questionnaires should be like. So we combined 5 different questionnaires together and got to a consensus of what we need to ask. And Bridie, who is an excellent sort of support system that we had, and helped me understand qualitative research a little bit more as well. So I have had a lot of helpers along the way, and thank you. That's my email address.